The subarachnoid space of the brain extends directly into the orbit of the eye. When cerebrospinal fluid pressure builds inside the skull, that fluid is forced down the optic nerve, physically expanding the retrobulbar dural sheath. In children, elevated intracranial pressure is an acute neurological emergency. If left unchecked, the mounting pressure forces brain tissue downward, leading to fatal brainstem herniation. Measuring that pressure directly requires drilling into the skull and placing an invasive catheter. This is the clinical gold standard, but it exposes the child to serious hemorrhagic and infectious risks. To bypass those risks, physicians turn to point-of-care ultrasound, or POCUS. By scanning the eye, they measure the optic nerve sheath diameter, using its width as a non-invasive proxy for internal fluid pressure. Relying on a non-invasive proxy is essential for safely managing pediatric neurocritical care. But doing so requires interpreting the ultrasound data with absolute precision. Clinical consensus correctly holds that POCUS is highly accurate at detecting the presence of elevated pressure. A wider optic nerve sheath confirms hypertension. A prospective observational study from the European Journal of Pediatrics challenges how we act on that expansion. The data shows that while POCUS is an excellent binary detector for high pressure, it completely fails to stratify clinical severity. Treating the ultrasound measurement as a linear pressure gauge, assuming a wider sheath means a patient is closer to herniation, can lead to severe misjudgments in emergency triage. Before interrogating the limits of the tool, the researchers had to validate its structural accuracy. The study enrolled 90 children. Those with clinical signs of elevated pressure presented with a significantly expanded mean sheath diameter of 5.63 millimeters, compared to 4.35 millimeters in healthy controls. An ultrasound measurement is only reliable if it avoids operator bias and anatomical anomalies, meaning both eyes must yield the exact same result. This bland Altman plot assesses agreement between the right and left eyes. Data points cluster tightly around the zero line on the y-axis. The mean difference between eyes, marked by the red dashed line, was a microscopic 0.0044 millimeters, p-value 0.74. POCUS consistently provides reliable and symmetrical data. With the measurement validated, we can examine its physiological boundaries. The pediatric optic nerve sheath naturally grows and widens as a child develops, typically stabilizing around age 10. In healthy controls, we see a steady upward trend correlating sheath diameter with age. In cases of acute intracranial pressure, rapid dural expansion overrides baseline physiology. The pathological measurements cluster high on the y-axis and remain entirely flat across all age groups. Because natural developmental growth plateaus around age 10, attempting to apply a single universal diagnostic threshold across all pediatric patients is mathematically impossible. These dual receiver operating characteristic curves divide the cohort into two distinct age-stratified diagnostic buckets. The models identified two exact actionable cutoffs for diagnosing elevated pressure: 4.91 millimeters for children under 10 and 5.27 millimeters for children over 10. Pathological expansion masks normal age progression. Clinicians must apply these specific age-stratified thresholds to accurately screen for hypertension without generating false positives. This brings us to the core clinical assumption. If high pressure pushes the sheath wider, then exponentially higher pressure should result in an even wider sheath. Severe intracranial pressure presents with profound neurological deficits, typically indicated by a Glasgow Coma Scale of 3 to 8, or the onset of Cushing's triad. This box plot chart compares sheath diameters against mild, moderate, and severe clinical classifications. Notice the horizontal alignment. The median black bars do not scale upward with severity. The Kruskal-Wallis test confirms a p-value of 0.66, definitively proving the lack of statistical variance between groups. The data is tightly compressed. The median measurement for mild cases is 4.93 millimeters, 5.53 for moderate, and 5.7 for severe cases, despite massive differences in the patient's actual physical danger. The correlation coefficient between the ultrasound measurement and clinical severity is a mere 0.054. The optic nerve sheath acts strictly as a binary alarm bell for hypertension. Clinicians must rely entirely on physical neurological signs, not ultrasound measurements, to determine the actual degree of danger. While the ultrasound fails as a static severity grader, it excels as a dynamic therapeutic tracker. The researchers tested two standard hyperosmolar therapies: 3% hypertonic saline, and 20% mannitol. This line graph tracks the efficacy of both drugs by monitoring changes in the sheath diameter over a 48-hour treatment window. Both agents trigger a progressive, statistically equivalent reduction in sheath diameter, evident in the parallel downward slopes of the blue and red lines. This dynamic reduction confirms that both hypertonic saline and mannitol are viable, equally effective options for managing acute intracranial pressure. The data outlines a strict clinical algorithm. Step 1. Screen for the presence of pressure using the precise age cutoffs of 4.91 and 5.27 millimeters. Step 2. Upon confirming the presence of elevated pressure, initiate treatment with either hypertonic saline or mannitol. Step 3. Monitor the patient's physiological response by tracking the dynamic reduction of the sheath diameter through serial ultrasounds. And crucially, never scale the aggressiveness of an intervention based on the absolute width of a single initial measurement. Point-of-care ultrasound is highly reliable for binary triage and therapy tracking if clinicians respect the absolute boundary between anatomical